Hi everybody, I'm Dr. Michael Richmond, a double board certified cardiothoracic surgeon. And today I want to talk to you about deep venous thrombosis. Specifically, I will talk about the pathophysiology, the risk factors, and the treatment. Although I could give a long lecture, 30-minute formal lecture on this topic, I will do my best to keep it brief while touching on the key points. So what is deep venous thrombosis, or what is known as a DVT? Simply put, a DVT is when a blood clot, known as a thrombus, forms in one or more of the deep veins of the body, usually in the legs, but can also occur in the pelvic veins or in the veins in the arm. Most commonly, it occurs in one leg. Okay, so now, a little on the pathophysiology. And you probably don't remember this from high school biology, but arteries carry blood with oxygen from the heart to the rest of the body, and they have muscles in their walls, which act as a pump. Hence, when you feel for your pulse in your wrist or your neck, you're feeling the muscles pump in the arteries. Veins, on the other hand, have no muscles, and blood returns back to the heart with no oxygen in it passively. It is increased by walking, or running, or exercise, and also raising your legs above your heart. Okay, so that's how blood gets back to your heart, essentially. That's why when you're sitting for a long period of time, let's say in an airplane or in a car, your legs may tend to swell. So what are the risk factors for deep venous thrombosis? Okay, they're best conceptualized by something we call Virchow's triad, which is three things: venous stasis, endothelial injury, and hypercoagulability. Venous stasis means the blood that travels to your heart doesn't flow well, and this occurs with immobility. For example, did you have a recent hospitalization, major surgery, or did you travel a long distance sitting in a car or an airplane? The second thing, endothelial injury, refers to damage to the vein itself and may result from trauma, like did you get kicked in the shin or the calf? Did you have recent surgery or inflammation? Hypercoagulability, which is the third thing, means the blood is thick and has a propensity to clot. This can be inherited, and such conditions are called like a factor V Leiden deficiency, a prothrombin gene mutation, a protein CRS deficiency, and that usually somebody in your family had it. Or it can be acquired. Cancer patients, pregnancy, people on hormones, birth control pills, obesity, smoking, acute infection, and chronic inflammatory disorders. Okay, those are the main causes. And also in the setting of acute inflammation, such as COVID-19, predisposes to deep venous thrombosis. The relative contribution of risk factors varies. Acquired factors like recent hospitalization, surgery, trauma, cancer accounts for most cases, especially in older adults, while inherited clotting disorders are more relevant in younger patients, or those with unprovoked, in other words, they just happened, events. Epidemiologically, the incidence of DVT increases steeply with age, and most cases are associated with recent hospitalizations or medical illness. So what is the main risk of a DVT? Well, that would be a pulmonary embolism, which we've all heard about. And that's when the clot travels to the lungs and can cause several problems, including death, which obviously is the worst problem. In the United States, the estimated annual deaths from pulmonary embolism are 60,000 to 100,000 a year. Fatal pulmonary embolism is a major concern. Up to 25% of PE cases present as sudden death. So how do we manage DVTs? Well, management of below the knee, which we call distal DVTs, is nuanced. Isolated DVTs confined just to the calf veins are common, and they're mostly, account for like half of all distal DVTs. And most of them resolve spontaneously and carry a low risk of a pulmonary embolism or extension upwards, compared to ones that start above the knee, and those are called proximal DVTs. However, anticoagulation or blood thinners is recommended for patients with severe symptoms or risk factors for extension, like active cancer, prior DVTs, recent hospitalization, or marked immobility. Meta-analysis and guidelines show that anticoagulation reduces recurrent pulmonary embolus and DVTs, but increases clinically relevant non-major bleeding. The effect on pulmonary embolus is uncertain, however, but for low-risk asymptomatic patients, surveillance with serial duplex ultrasound is fine, and we follow that. And if the clot progresses upwards, then we start anticoagulation. Patients who have proximal above-the-knee DVTs, we start anticoagulation early. So in summary, it's a multifactorial problem with Virchow's triad providing a useful framework for treatment and cause. If you notice swelling in one of your calves with or without shortness of breath, it would be prudent to go to the hospital and have a lower extremity venous duplex, which is a fancy ultrasound that looks at the veins, the structure, and the blood flow inside, and you would see a clot. So with that, I know it's a little complicated. Try to make it easy. Hope you learned something today. Thank you for listening. If you have more questions, you can go to my website, www.paladinmds.com, and signing off. Thank you.